a successful transplant in one line, what would be Dr. Sashikant Apte's version of it?
Uh, at end of 5 years, there is no evidence of a primary disease. There is no evidence of a graft versus host disease. There is no evidence of a rejection. That is the true successful transplant.
One word for your 900 plus transplants journey.
Thank you to everyone who supported us, the God, the families, my wife, our team, the hospital group, the administration, because we were one of the early groups to start the transplant. And there was faith shown by administration right from day one. Foremost, most important, our patients.
Yes.
For accepting us,
Showing
to
the
come to
trust.
us and showing trust in us. They were identical twins born out of a IVF. One child got acute lymphatic leukemia. We started treating, and within 6 months, second child also got acute lymphatic leukemia. They were identical twins. And we requested Dakri that one donor should donate for two children because he was matched with both,
Yes.
being identical twins.
Yeah.
In fact, last year, at end of 3 years, donor accepted to reveal the identity. And we had what is called as a patient-donor reunion in Pune.
Oh, lovely.
That happened somewhere in September, October last year.
Bone marrow transplant, often seen as the last resort. But in reality, it represents one of the most powerful and curative therapies in modern medicine. With advancements redefining outcomes and expanding donor possibilities, the field has evolved far beyond traditional boundaries. Yet, behind every transplant lies a complex balance of science, timing, risk, and deeply human decisions. In this conversation, we explore not just the medicine but the journey of hope, resilience, and the evolving future of cure in hematology. Joining us today is Dr. Sashikant Apte, one of Pune's most distinguished hematologists with over 3 decades of experience in managing complex blood disorders. As a senior consultant hematologist and director at Sahyadri Manipal Hospital, he is widely respected for his clinical excellence and patient centric care. A pioneer in the field, he established Pune's bone marrow transplant program and has performed over 900 plus transplants so far. That includes 100 plus allogenic procedures as well. His expertise in conditions like leukemia and aplastic anemia has set new benchmarks in treatment outcomes. With training from premier institutions in India and abroad, he brings global standards to local practice. His contributions to research and collaboration with international leaders have significantly advanced hematology care. Today, we are privileged to gain insights from his remarkable journey and vision. So, without further ado, let's welcome Dr. Sashikant Apte. Hello and welcome to Sahyadri Health Talks. I'm Dr. Tushita, and today we have with us Dr. Shashikant Apte. नमस्ते सर,
नमस्ते।
कैसे हो आप?
हम ठीक है, आप कैसे हो?
बहुत बढ़िया। अभी आप आ गए हो पॉडकास्ट में तो फिर तो और ज्यादा बढ़िया है ना। सो वेलकम ऑन सह्याद्री हेल्थ टॉक्स एंड आई नो आई एम लिटिल लेट बट आई हैव super packed episode of lot of information which is right here. But before I dive into this, I want to congratulate you and your team for 900 plus bone marrow transplant procedures. So big congratulations for this humongous number. So Kaisa, how was this journey, sir? From day one. Do you remember your first bone marrow transplant?
Yes. First bone marrow transplant, I did it in Inlax Hospital in 1999.
1999.
And that patient is still alive with 27 years of disease-free survival.
Lovely.
She was a case of autologous transplant for multiple myeloma. And second case was a thalassemia major child who underwent allogenic transplant in the same month. And he is also doing well, pursuing career in US. So it is very gratifying to look back and see all the things. And Sahyadri transplant program started in 2003 after the hospital was opened in part. And since then we have done 900 transplants.
So you are there from day one of Sahyadri and
Yes.
being a part of this bone marrow transplant team. So you always wanted to do this? Was this your dream, or how did you become one?
See, it is always the dream of any clinical hematologist
Acha.
to do a bone marrow transplant. I came to this city in 1998 and started developing a department of hematology, and always dreamt of doing a bone marrow transplant in this city. That time transplant was only happening in CMC Vellore and Apollo Chennai. Even Tata Memorial program had not started. And 1999 we were the third program to start in INLAX and then take it over to Sahyadri hospitals in 2003.
So being pioneer in this entire field, right? So you have seen the transition in when it comes to the terms of newer technologies, or every perspective of this bone marrow transplant particularly changing and evolving. So if we have to start from something very basic, like if you have to quickly explain us, what happens in a bone marrow transplant and who needs it, something to start with, very basic.
So basically there are two conditions, Dr. Tushita, that require bone marrow transplant. Any disease originating from the bone marrow, it can be immune disorder, it can be congenital problems. So there are a lot of genetic diseases which can be cured by bone marrow transplant. And there are a lot of acquired conditions like leukemias, blood cancers, lymphomas, multiple myelomas that can be cured by bone marrow transplant. One thing is very important, that you have to be properly trained, because handling a 10-kilo child for bone marrow transplant is not a simple thing.
Yes.
So it is very intense therapy, because you are virtually changing the complete system. One thing is there is no operation involved. But there, more than the operation, the things happen.
Yeah.
First and foremost, we have to destroy the patient's bone marrow and feed that patient with normal stem cells.
Acha.
And then the disease gets cured. This is the general principle. It takes long time for immunological recovery to happen.
Acha.
Again, as I said, though it is called transplantation, there is no surgery involved.
Yes.
In the path.
Yes.
The person who goes to operation theatre is a donor when we are doing a bone marrow harvest.
Acha.
Peripheral stem cell harvest is done from the blood in a blood bank with a cell separator machine. So these are the basic things that are involved.
That happens.
That happens in bone marrow or stem cell transplant. Now the term coined is stem cell transplant.
Acha.
The initial term, when the pioneers like E. Donald Thomas first did the transplant, they had used bone marrow as a source of stem cells.
Yes.
But eventually people realized that you can push the stem cells in peripheral blood.
Yeah.
And you can collect stem cells from peripheral blood from a donor. Because in peripheral blood collection, there is no role for anesthesia. Person is conscious. Whereas when we do bone marrow harvest, you have to have a donor in OT under general anesthesia, and we do the harvest. Because bone marrow volume is quite high. I remember in Australia, while I was a trainee, we had to harvest 3 liters of bone marrow from a donor to give it to the patient.
Oh.
So 3 liters marrow you are taking out cannot be done under general without general anesthesia.
Yeah, it has to go through a proper general anesthesia.
Proper general anesthesia. And that's a worry, because every anesthetic procedure has certain risks.
Yes.
And we always worry that the donor should not have anesthetic risk. But very few complications have happened so far.
Yeah, so that's wonderful to know. So how has this concept of curing versus caring has evolved over your experience of 900 plus? I'm just fascinated with the number 900 plus bone marrow transplants.
I'll tell you, Tushita, that more than 900, I would say the last 36 years has taught me every day something new. And the concepts of cure versus care have evolved. Every doctor wants to cure every patient he sees.
True.
That's the basic motive of the medical profession. And we take pride in curing difficult cases.
Yes.
But we must understand where to draw a line. And that is very, very critical. Not to do. It is easier to take a decision to do. It is more difficult to take a decision not to do. And there are various parameters, multivariate issues arise, and you have to be very conscious where you want to go, where you want to give a cure or whether you want to give a care. And that decision should be decided on day one when you see the patient.
Yeah.
And I try to do that on every patient, whether it is malignant, transplant or non-transplant. That is my philosophy. That's what my teachers have taught me, and even I have evolved, that we cannot cure everyone. We have to understand we are not technicians. We are not like people just changing the wheel of a car.
True.
We have to take care of a complete car.
Yes.
So this is the way I find out that every patient we may not be able to cure. We should be judicious because these treatment options have their own complications.
True.
And what is more important? Quality of life, quantity of life, stage of the patient, the stature of the patient. Because sometimes patients are so sick,
Yes.
you can't take them to an intensive procedure like allogenic stem cell transplant.
True. So as you were speaking about selection of the patients, right? So what are the most critical factors when it comes to selection of the right patient for the transplant, and how do you manage communicating it to the family at the same time? So we are talking about two things. One is the patient selection. The other one is the counseling part of it as well. So how do you deal with it?
Correct. This is a very critical part. And that depends on what type of disease the person is having and what type of condition you are going to do the transplant. I'll give you an example. Like a patient like beta thalassemia major, he is going to require blood transfusion very now and often then. And today we know that the results of bone marrow transplant are best with condition like thalassemia major if we do it early with patient having received less than 20 blood transfusions. So every blood transfusion stimulates the immune system. Younger the age in these genetic conditions, the conditions before the patient becomes too sick, because there are certain conditions called primary immune deficiencies. There, the patient becomes very sick because they get recurrent infections.
Now, because the immunity is very low.
Very low, correct. And there are huge diaspora of these diseases. And these situations, I would like to do very early transplant. The youngest transplant we have done so far is 6-week-old child. Because we were anticipating an immune deficiency child. There was a strong history. We had counseled the family. And counseling the family becomes very important. Because it's a near and dear one to the patient. It's never 100% success.
It's a child. Most of the time, it's a child, right?
And with a child undergoing that agony, it is very difficult for parents to see. But if you counsel them properly, if you tell them the scientific background, a lot of people do understand and they come forward. There are a lot of people, they get scared and they unnecessarily delay.
Yeah.
But one of the major reasons of delay in these genetic conditions transplant is the finances.
Okay.
Genetic diseases are common in certain parts of India or majority part of India, because a lot of our communities, we have consanguineous marriages in lower socioeconomic strata group.
Yes.
And because of the consanguineous marriages, these diseases are more common.
More common.
And that is where the role comes into play. Whereas you have a 40-year-old person who has 2 children who are in class 8 and class 6, he has got a malignant condition. He is the only breadwinner of the family. If the donor is available and if he is in a proper risk category, proper remission, it is better to do transplant in the correct window. Because in acquired condition, especially leukemias, blood cancers, you get one good window to transplant it.
Achha.
If you miss that window, the outcome can be poorer.
So when we talk about donors, as you spoke about donors, right? So there's a common understanding in layman, from a layman's perspective, ki, only a sibling can be a donor. Now we are also hearing about something called as haploidentical transplants. So which has helped a lot when it comes to the donor selection, breaking that barrier. So help us understand, is it true to begin with that only siblings can be donors?
No, it's a myth that only siblings can donate the bone marrow or stem cells. The best donors are family matched donors. We are talking of allogenic transplant. When we talk of allogenic transplant, we talk of a donor. In autologous transplant, it is own cells used, so there is no question of a donor.
Achha.
So donor can be a sibling, and there is a 30% chance that a sibling may be a complete match. And when we do the transplant or when we select the donor, we do a test called as the HLA typing.
Achha.
Like all of us have blood group A, B, OB, AB, and O. Every individual has a group on the white blood cells and the tissues, which is called as the human leukocyte antigens.
Achha.
If HLA match is 100%, then the results are the best. And to find a 100% HLA match donor, the best chance is the sibling, because you can have nearly 30% match. Among the generation, that is parent to child, the match chance is around 1%. Like we have done 900 transplant. 14 patients have been across the generation.
Achha.
Majority of them have been parents, but in one child, we have done a grandfather to child match.
Oh,
He was a
okay.
complete match. It was a surprise to us,
Achha.
and we have done a transplant. Now we have donor registries, because if you see, a lot of families have single child.
Yes, yes.
It's
I
a
was
single
coming to
child
that.
now.
That these days, lots of families have single child. So how do they manage?
Exactly. So with the single child, there is no sibling donor available at all.
Yeah.
So there are a lot of registries. There are voluntary donor registries. There are two registries in India which are very well functioning. One is called Datri at Chennai,
Achha.
and other one is at MDR at Mumbai. And there, these are the voluntary donations. We have done around 100. These transplants are called as match unrelated donor transplant. It is a HLA match, but the donor is not related, and there is a complete anonymity maintained between donor and patient. That is the second set of allogenic donors outside the family.
Achha.
And now we have understood the concept called haploidentical transplant.
Yes.
Like every child and the parents, they will be 50% match.
Achha.
Mother will be 50% match, father will be 50% match. Because the genes have, HLA antigens have come from father and mother. And today we have reached the situation where we are doing 50% match transplants from unmatched donors, which is possible.
Achha.
And with the development happening, I'm sure that within few years, we should be able to do complete HLA mismatched donors transplant in allogenic setting. The science is moving very fast. Nobody 50 years back, when Donald Thomas did a transplant, would have thought, yes, we can do a mismatch transplant. And last source is umbilical cord stem cell transplant.
Achha.
But over a period of time, umbilical cord as a donation source for the stem cell has dropped down for various technical issues. So this is the way we select the donors. Always HLA match. Sibling or a family donor is the best donor, followed by the match unrelated donor, and then the mismatch haplo or a mud donor. So these are the vista, and that's why today the concept is every patient has a donor.
Achha.
In a close-knit community like Indian community, like recently we did a search for a thalassemic child. We have 59 100% matched donors.
Achha.
So as I said, we found 59 donors for one patient. It means those donors also have a match among them.
Achha.
So any one of them develops a blood malignancy, they have donors available. With this donor pool expanding, still we may not have a complete match donor even in unrelated donor registry. There we go to the haplotransplant or a haplomatch transplant.
Okay.
So this is the sequence how we would go in selection of a donor. Sometimes multiple donors are available. Then we prefer a young donor. We prefer a donor with the same group. We prefer a donor, if it's a female, then nulliparous woman who has not delivered a child, whose pregnancy stimulates these things. So there are a lot of variables that we choose while selecting the donor.
So as we speak about selection of donor, it's like, thanks to the advancements which we have today, that it has become more, simpler and all that stuff. But still, like any other medical procedure, there exists the risk of the chances of risks involved, and then the percentage of cure happening. And most importantly, the thing which we feel here is it's a kid who is your patient. So the family, the emotional angle to it, how do you balance out all these parameters while you talk to your patients and convey them that this is what is going to happen?
See, it is is here to convey the issue of transplantation in cancerous patients. Because everybody is scared of cancer.
Yes.
But people do not understand what severity immune deficiency can have in a newborn child. What a thalassemia major means to a newborn child. A lot of people, when you explain them, these are the complications, this is the whole procedure. Because when you do allogenic stem cell transplant, nearly 6 to 12 months is the critical period you have to support the patient. Once 6 months are over, once 12 months are over and patient is doing well, the complications have receded, then we slowly start having a sigh of relief. And once the patient completes 5 years, then we call the patient is cured. Because whenever we do transplant, everybody is worried about the intensive chemotherapy. Or we can use radiotherapy, that is total body irradiation, to prime the patient to accept the donor stem cell. This worry that the WBC is going to fall, patient is going to be at a high risk of infection, people delay the transplant. So sometimes what happens in an immune deficiency, we have made a diagnosis at age of 4 months. Because child has got 2 episodes of fever, infection, the pediatrician has worked up the child is turned to have a severe combined immune deficiency, referred to us for transplant. We explain them pros and cons, side effects, toxicities. Family gets scared. Will the child stand? But we must understand these are the lethal conditions. Unless you transplant them, it is very difficult to save this child and even go with the child beyond 2 years, 3 years. So that part is very critical, and proper counseling of the patient. And here, our old patients play a very important role. We always have our patients very strict follow-up. So we request one of the patients who has already undergone for that condition to talk to the family.
So it kind of gives them the emotional support, also the mental peace.
Correct. Because when they see somebody who has undergone the same, I'm not saying that it is 100% curative, because there are 10% children who would reject the marrow, who would have infections, who would have infective deaths. But we have to accept it. Certain mortality, we have to understand it happens in any procedure, and then we go ahead. But once you counsel them, generally the parents agree. And over a period of time, like 20 years back, it used to be a much more difficult, what I should say, algorithm to explain. But over a period of time, so many things, new things have happened. The movies have used the topic of stem cell transplant. The plays have used the topic of stem cell transplant. There is a media publicity. People are aware of these situations and they come forward for the transplant. Well, you must understand, a match unrelated donor, patient has no relation to the donor. Till the donor, for the altruistic reasons and the philanthropic reasons, is donating. So I'm very thankful to all my donors who have donated stem cell, and especially mud donors, where they have donated the cells for these children.
That's lovely to know that people are really coming out and helping others. Now let's talk about GVHD, which is graft versus host disease, and what about that complication? How real it is and how frequent it is?
Fine. In any allogenic transplant, when we transplant, we are worried about 5 major complications. First is rejection. You put in the stem cell, but the patient rejects it. Patient goes to square one. Second is patient accepts it, or before acceptance also, patient gets infected either by fungus, either by bacteria or by viruses, and they have an infective death. Third is toxicity of the treatment regimen. That also can cause liver cell failure, kidney failure, sometimes brain issues. And then we have graft versus host disease. And graft versus host disease happens because, I'll give an example. Like everybody is aware of a kidney transplant. A donor kidney is taken and put in a pocket where it rests and functions. But this kidney doesn't come in contact with lung. This kidney doesn't come in contact with skin. Doesn't come in contact with liver.
The other vital organs.
But when you do stem cells, when I put a stem cell from a donor to patient, the donor lymphocytes are going to start circulating in the patient's system. Over a period of time, even though there is a match, the cells may recognize that this is not my body.
Acha.
And these cells reject the patient's body, patient's organs, and it is called as a graft versus host disease.
Acha.
Rejection is host versus graft disease.
Acha.
It is more common in solid organ transplants. Rarely we can have rejection. The causes of rejections are different. And the chronic graft versus host disease depends on, and there are two types, acute and chronic. It is the arbit figure that if happens in first 100 days, it is a acute GVHD. If it happens after 100 days, it is a chronic GVHD.
Acha.
That is not true. There is a crossover. And acute GVHD has 4 stages, 1, 2, 3, 4. If you are in stage 4 acute GVHD, death rate is very high in majority of the centers. Chronic GVHD is more frustrating disease. It is a nagging disease. It may happen after 6 months, 12 months. First 6, 12 months may go very well. Patient is very happy. You are reducing immunosuppressions. You reduce immunosuppression and GVH happens. And it can be very, very debilitating condition.
So it stays for the rest of the life.
Majority of the times you may be able to control it, but few cases it keeps nagging them. And sometimes, because I have one girl who had a very bad chronic GVHD, the only treatment she has, the lung is affected. The only treatment is lung transplant. The lung is so badly damaged, we took all the care, all newer medicine. She joined, she participated in clinical trials, newer drugs were used, but it never helped her. So there are these kind of patients who succumb or who have a bad quality life because of chronic graft versus host disease. And when we counsel the families, we also tell them about quality of life post-transplant and issues with quality of life.
So, what would be the biggest challenge that you find in Indian, society or Indian context when it comes to the treatment or post-treatment of such patients?
See, there are a couple of important issues. One issue of patient understanding has definitely improved. The patients undergoing transplants every day are increasing. Newer and newer centers are coming up. Like to give an example, like last year, around 4,000 transplants happened throughout the country. And there are nearly now 160, 170 centers regularly doing transplants. Some centers are huge volume like us. Some centers are doing small volume transplant. A lot of transplant units have single physician. Like I was single physician till 2009.
Yes.
And 2009, Dr. Kannan, my first student and colleague, joined as a second consultant. Then we have expanded. But it takes time. So that is the greatest challenge. How many transplants you can do? What age you are comfortable? Like our team, we are very comfortable to do even very small children.
Yeah, you said 6 weeks you did the first.
Because what happened, that family came to us when the lady was 25 weeks pregnant. There were 3 deaths in the family at the newborn age or infantile age because of immune deficiency. And they wanted to do the antenatal diagnosis. I said, at 25 weeks, we can't do antenatal diagnosis because we cannot terminate the child. So we will be ready. At delivery, we immediately work up the patient. And if the patient is going to be immune deficient, before they have a infective episode, we'll transplant. And we decided we'll straightway go with a haplotransplant. So we were ready. When the child was born, we did the HLA typing. Mother was 75% match. Father was 50% match. So we used the mother. And today child has completed 6-7 years. He's going to the school. He's living a normal life. See, this is the planning and anticipation. So, and luckily family agreed because they had seen 3 deaths below age of 6 months. So they were ready to take the risk because we had missed the window of doing a prenatal diagnosis. If they had come to us at 10th week, we would have done the prenatal diagnosis on the fetus, and fetus was obviously involved. We would have terminated the child. But when they come at 25, 26 weeks,
all we can do is be prepared once the child comes.
See, if the child was normal, obviously we would not have done the transfer.
Yeah.
And this was a consanguineous marriage. The parents were uncle-niece.
Acha.
Because they shared that recessive common gene,
genes.
and it came to the child from both the parents.
Sure.
So that's why, as I said, the consanguinity is a major risk factor in some of the genetic disorders. Leukemias, there is no risk factor like this. Smoking is not a risk factor. But yes, once the patient has to undergo chemotherapy, undergo transplant, they have to have certain discipline. And certain discipline they have to follow. Because infection risk is very high for first 6 months. Because it takes slow time to immunity to settle down. And settle down. Means even you would be surprised, Toshita, that when we do stem cell transplant, after 1 year, we vaccinate even a 40-year-old patient. Because during the transplant, the system has forgotten the memory about polio, diphtheria, tetanus. So you have to restart the vaccination program on the patient. And that's a very fascinating thing that I find. Another fascinating thing, that a female donor, female patient gets a male stem cell, the blood cells are going to show 46 XY chromosome. Whereas other cells will have 46
XX chromosomes. Yes.
Okay, so it's a very fascinating thing.
Yes.
Third fascinating thing I always find, that the blood group changes.
Correct.
Like the chromosomes change, the blood group changes.
Yes.
Like person is A positive, receives B positive blood. Over a period of time, post-transplant, the blood group becomes B positive. And it creates a huge issue in the blood bank in grouping and cross-matching the sample.
Yes.
So it's a very amazing, fascinating thing how the cellular changes happen.
And how the body also gets slowly accustomed to the entire thing.
Exactly. So it's a very fascinating thing.
Yeah, I totally agree. And then, we are also seeing so many emerging therapies which are coming up. You have already seen in your, last so many decades of experience that you bring in, and upcoming newer technologies, or something called as CAR-T procedures or cells, I think. What excites you the most about this entire process which is coming up?
No, so CAR-T is a very fascinating development. Before CAR-T, especially with lymphoma and myeloma, the algorithm for a relapse case or a high-risk case, a relapse case of lymphoma or a high-risk myeloma always used to undergo autologous transplant. Post-autologous transplant, the only post-autologous transplant relapse, the only treatment available was allogeneic stem cell transplant.
Yes.
And allogeneic stem cell transplant results in myeloma and lymphoma were quite pathetic. They were around 30%. Whereas when CAR-T came, so a young patient relapsed lymphoma would undergo autologous transplant, or may undergo straight away CAR-T now, because the data is emerging. And patient relapses. Suppose he has undergone autologous transplant or has had a chemotherapy, patient has relapsed. We can take out patient's own T cells and trigger them to attack the malignant B cells.
Acha.
So this is the principle to explain for CAR-T therapy. It's a very exciting therapy. But every exciting therapy, every therapy has its own complications. Cost-wise, the initial cost may be low. But suppose something called as a gamma globulinemia happens, they are very prone to infections. And then you have to support them with injectable immunoglobulins every month. It's an expensive medicine. But yes, it is a tool, and it's a very important tool. And I'm sure, like the transplant evolved, these cellular therapies will also evolve and will be a very important tool in treating malignancies in human beings. Now CAR-Ts are being prepared for solid tumors also, like stomach cancer. There is a data published. Melanomas, renal cell carcinomas. These things are evolving, and they will evolve. They will evolve, but it will have its own price. We have to have a proper conscious health economics, because in our country there is hardly any government support for this kind of
True,
things.
very true. And insurance also doesn't.
Correct. And majority of the transplant centers are in private sector.
True.
It is an expensive therapy. People don't understand why these therapies are expensive. Because it requires that kind of an investment It requires that kind of a drilling. It requires that kind of a teaching and training. Because it's not a simple tool, just like giving an injection.
True.
It should be used very methodically and cautiously. These new technologies.
Okay, so now moving on to the next segment of Sahyadri Health Talks, which is a few questions which I ask you. This can be myths or facts, and a few quick one-liner answers. I lovingly call this as rapid fire round.
Sure.
So, starting with the first one, bone marrow transplant is always the last option. Myth or fact?
No, it's not. It's not a myth. Some of the cases, it is the last option. But some of the cases, it can be the first option. उदाहरण द्यायचं झालं तर pediatric acute lymphatic leukemia standard risk, it will be the last option because chemotherapy देऊनही 90% पेशंट बरे होतात. These group of patients, I would not use allogenic transplant as an early tool because it may kill the patient who could have been cured. But certain conditions, it can be very early option like immune deficiency in children, high risk acute leukemias. Like आता एक पेशंट आहे, शी इज अ 30-year-old पेशंट, त्यांना हाय रिस्क अक्यूट मायलॉइड ल्युकेमिया आहे, शी हॅज अचीव्ड रेमिशन, वी आर गोइंग हेड विथ ट्रान्सप्लांट नेक्स्ट वीक, शी हॅज रिसिव्ड 2 सायकल्स. सेकंड सायकल त्यांना लागली कारण त्यांना पैसे जमा करायला थोडा वेळ लागला, सो आजार परत येऊ नये म्हणून आम्ही ट्रान्सप्लांटला केमो दिली. पण आता वन्स दे आर रेडी विथ द फायनान्सेस, वी आर गोइंग हेड विथ ट्रान्सप्लांट बिकॉज इफ यू डोंट ट्रान्सप्लांट हर, the disease will come back. So
it depends on patient to patient.
Patient to patient and the condition. For what condition you are transplanting? That is where the key lies.
Okay. So only siblings can be donors. True or false?
It is completely false, as we already discussed.
Yeah, you just said there was a grandfather and the grandchild.
And there is unrelated donors. The number of unrelated donation and unrelated donor transplant happening is huge. Because as I said, a lot of families are one child families. जब एक ही बच्चा है घर में,
तो सिबलिंग
कहाँ से आएगा?
ठीक है. Bone marrow donation is extremely painful. Myth or fact?
Bone marrow donation happens in operation theatre. The donor goes to operation theatre. Donor is given general anesthesia. Patient is completely anesthetized. And the procedure is done like a bone marrow aspirate and we collect in a bag. So bone marrow donation हे पेनफुल नसतं. आणि बोन मॅरो डोनेशन हे पूर्णपणे अनेस्थेसिया खाली ऑपरेशन थिएटरमध्ये घडतं. ज्या पेरिफेरल स्टेम सेलमधून आम्ही घेतो त्या ब्लड वेसलमधनं स्टेम सेल घेतल्या जातात. दॅट इज ऑल्सो नॉट व्हेरी पेनफुल. आणि थर्ड सोर्स ॲज आय सेड इज अ अम्बिलिकल कॉर्ड where the stem cells are collected at delivery. Again, that is not a painful procedure.
Okay. Transplant means guaranteed cure. Yes or no?
No. There are 10 to 15% patients who could either die of the complications like GVH, infection. There are 2 to 5% of the patients who will reject the graft and land up in relapse. So there are 15% patients who do not get cured. And another 5-6% patient, the disease relapse occurs. So it depends where we are talking, but it is never 100% cure.
Okay. Older patients cannot undergo transplant. Myth or fact?
It's a myth. If the person is fit, I have done autologous transplant up to age of 75. Patient was very fit. Our oldest allogenic transplant for acute myeloid leukemia, we had 2 patients who were 71 and 72. But they were very fit. See, we must understand what is the biological age of the person. Person may be 72, but he is physically so fit, no medical problems, no comorbidities. He may be as fit as a 40-50-year-old man.
Yes.
Whereas a chronically ill patient at age of 40 may be biologically 80. And that may be a more difficult transplant than a 72-year-old fit allogenic transplant.
So age is definitely not the only deciding factor.
Yes, not the only deciding factor.
The toughest phase of a transplant in one word?
Always. When you go transplant, first 3 to 4 weeks is tough from different angle. From first day 30 to day 180 is tough from another angle and beyond 180. Because there is a hanging sword of certain complications viral infections, even late, and relapse. When patient relapse post-transplant, it is a very difficult situation for the patient and family to accept it, and especially when late relapse happens.
Okay. Um, Infection or GVHD, what worries you more?
Both. Both are very worrying complications because they are interlinked. When patient gets viral infection, we reduce immunosuppression so as to help the immunity.
Yes.
When you reduce immunosuppression, graft versus host disease can worsen. So you are really on a seesaw balance when you are treating.
To strike the right balance between
Correct.
the two.
You have to strike the right balance and have a equilibrium attained. Because you try to treat GVH, you are giving more immunosuppression, there is more infection. You treat infection, you reduce immunosuppression, risk of GVH goes. So it can form a very vicious cycle.
So you can't pick one, and it's very
Correct. Very dangerous.
very dangerous. Okay. Peripheral blood stem cells versus bone marrow. Your quick pick in most cases.
See, in adults, in leukemias, in malignancies, I would definitely prefer peripheral blood. In genetic conditions, I will preferably prefer bone marrow because bone marrow has a less risk of a graft versus host disease. In a multivariate analysis, it has been shown that GVHD, bone marrow risk is less. It is not zero.
It's not zero.
But it is less than PBSC. So wherever the situation, we don't want GVH. Genetic conditions, we don't want GVH. In leukemia, we want GVH because there is an effect called as a graft versus leukemia effect.
Acha.
So when you get GVHD, the donor T cells are also killing if there are any remaining cancerous cell in the system of the patient. So GVH has its own benefits also, but it has its own perils.
One habit patients must strictly follow post-transplant.
Keeping cleanliness, having clean food, and having clean water is extremely, extremely crucial. Till their system settles down, they should not eat outside, have outside food, have cleanliness in food, because we don't want stupid complications.
Yes.
6 months down the line when everything is going on well.
Yeah.
Because it has happened.
Okay. Relapse after transplant. Common fear, but how often does it really happen?
Again, it depends on what condition you are you are treating the transplant. Generally, in genetic conditions, relapse rates also less because conditioning is different. But leukemias, there is always a certain risk of relapses, especially in high-risk group of leukemias. So there is a concept that has evolved now to give maintenance therapy with certain drugs.
Achha.
Like suppose you have FLT3 positive, then we have drugs which are used even post-transplant. Suppose there is a leukemic patient who has very high risk of relapse, we can do preemptively donor lymphocyte infusions.
Achha.
Same donors lymphocytes are separated and they are given. And these lymphocytes may induce graft versus leukemia effect.
Achha.
And these are the ways we try to negate the relapse rates.
Isolation after transplant, is it absolute or evolving?
No, it is absolute in a way because it definitely has a better results. But we had published the data, like even in first 30 days, that HEPA filtered rooms, they are definitely useful. I am not saying that they are bad. But some of the transplant can very well be done in a non-HEPA filtered rooms. But yes, when you are discharged, we don't allow the patient to go to the crowded places. They have certain isolation, but they can move freely at home. They should do certain gentle exercises, go for a walk at 5 o'clock in the morning in the area before the crowd comes up.
Yes.
So certain daily activities should be done, but they should be generally isolated and they should not come in contact with more people.
Bigger crowds or crowded places, right? Success of transplant depends on success of transplant depends more on whom? Doctor, donor, or patient?
All are very important. Most important is the patient. What is the patient's general condition? What is the disease status, especially when you are dealing with leukemia? When was the diagnosis made? Because there is a condition called aplastic anemia where blood doesn't form, which is very common in India. If their diagnosis happened 6 months back, they are infected, they can die during the transplant.
Mm-hmm.
Even donor selection is very important.
Mm-hmm.
And the treating team, like all the registries, have the split more than 10 years functioning transplant unit versus less than 10 year functioning transplant.
Mm-hmm.
The results are definitely different because every day we are learning new, every day we are getting a new confidence. But yes, the experience of the team definitely matters, especially in complex transplants.
Mm-hmm. So, if you have to define a successful transplant in one line, what would be Dr. Sashikant Apte's version of it?
Uh, at end of 5 years, there is no evidence of a primary disease. There is no evidence of a graft versus host disease.
Mm-hmm.
There is no evidence of a rejection.
Mm-hmm.
That is the true successful transplant.
One word for your 900 plus transplants journey.
Thank you to everyone who supported us, the God, the families, my wife, our team, the hospital group, the administration, because we were one of the early groups to start the transplant. And there was faith shown by administration right from day one.
Uh-huh.
And last and foremost, most important, our patients
Yes.
for accepting us,
Showing
to
the
come to
trust.
us and showing trust in us. It is very important that I say thank you to all these people.
I'm pretty sure we have a lot of audience who are watching this today, and they still have a big smile on their faces seeing you on the screen. So before we let you go, we have a ritual at Sahyadri Health Talks, which is we listen to some stories. So you have to tell us one story of your patient, any of your patients, which you remember has been very successful and has left a mark on your entire journey, and you really look forward to look back on that case.
There are two families, there are two cases I'll narrate. One was a patient family from Yemen. They had a congenital immune deficiency called LAD deficiency.
Acha.
One child was 9 month old, other child was 4 year old. Both of them had that condition.
Uh-huh.
Father was a complete match with elder sister.
Acha.
Yeah, brother was complete match with the younger
The
sister.
younger one.
So we did sequential transplant, two
Uh-huh.
transplant in a row.
Uh-huh.
There's another family. They were identical twins born out of a IVF.
Mm-hmm.
One child got acute lymphatic leukemia.
Mm-hmm.
We started treating, and within 6 months, second child also got acute lymphatic leukemia. They were identical twins. So
Identical.
stem cell defect could have been same. So we identified the stem cell defect with, it was a high risk leukemia. So we counseled the family, both the children need transplant.
Mm-hmm. Mm-hmm.
There was no match. We found one match in Datri registry.
Mm-hmm.
And we requested Datri that one donor should donate for two children because he was matched with both,
Yes.
being identical twins.
Yeah.
Luckily, donor also agreed. We did excess harvest.
Mm-hmm.
Cells were brought to Pune.
Mm-hmm.
One patient was transplanted on one day, second patient was transplanted next day.
Uh-huh.
Today, both the children are doing very well.
Mm-hmm.
In fact, last year, at the end of 3 years, donor accepted to reveal the identity.
Uh-huh.
And we had what is called as a patient-donor reunion in Pune.
Oh, lovely.
That happened somewhere in September, October last year.
Uh-huh.
And it was a very touching
Moment
moment
very
for
emotional
everybody.
moment. Yes.
For everybody.
Yes.
Everybody.
Yes. So, what has been the most satisfying part about your journey?
That people have shown faith. I got good colleagues. I got good teams. I got very good nurses. I always got the support from administration and support from my family, my son and my wife Netra. They have played a very, very important role and it's very satisfying. And it is very satisfying when the patients come smiling for the follow-up after 2 years, 5 years. We feel, okay, we have contributed something to science and society. And I feel very humble and thank God for giving me this opportunity.
How do you keep yourself so positive all the time? I always see you with a smile. I mean, I've
No.
never seen you without a smile. Always so positive.
Toshida, let me honestly tell you, if I have to be smiling all the time to give confidence to my patients.
True.
So it's a bad branch.
Yes.
There is a definite mortality involved in
True.
these procedures.
True.
So to face that, you should give the confidence to the patient and their families. And that's a very important part.
Great. So before we end this podcast, your final message to two set of people. One would be, of course, our first patients who are dealing with this and have to get a bone marrow transplant done. And what message do you have out for all of them? Maybe many of them are not able to reach you, so what message do you want to give out to all of them is my first question. Second question is, what message do you want to give out to all aspiring doctors who are looking forward to take up this stream, because it requires so much of efforts and positivity. So for both these set of people, what would be your final message?
So, to the patients, I would say की बाबांनो घाबरू नका. ही ट्रीटमेंट मोठी आहे, कठीण आहे, पण अशक्य नाही. Lot of centers are there who are doing these treatments. Don't delay if your patient requires transplant, because delay is one of the greatest risk factor in outcome for these patients. वेळेवर करा, पेशंटची कंडिशन चांगली असताना ट्रान्सप्लांट करा. पैशाचे अनेक वेळा लोकांना प्रॉब्लेम असतात, पण खूप डोनर्स आहेत, खूप दानशूर व्यक्ती आहेत की ज्यांच्याकडनं पैसे उभे राहू शकतात. पैसे उभे करणं ह्या ह्याच्यात सगळ्यात सोपी गोष्ट आहे, रादर दॅन पेशंट आणि पेशंटच्या फॅमिलीने तयार होणं. सो इट इज व्हेरी इम्पॉर्टंट दॅट द पेशंट्स accept if there is a need for transplant in the correct window, not to miss the window. To the young doctors, I would say it's a very fascinating branch, very exciting branch. We need more and more people. We are 1.4 billion population. Still not enough centers are there to do all the transplants. We need more manpower, we need more dedicated people, and we need more leaders in this part to develop various new centers in various other parts of the country which will benefit the community. Thank you.
That's great, sir. Thank you so much for giving us this time today. It was wonderful to have this discussion with you. And we look forward to have you again on this podcast, maybe with some other topic or with something else in near
Sure.
future. Thanking you once again. This is Dr. Tushita signing off, Sahyadri Health Talks.